Well, I'm very excited to spend the next 50 minutes or so talking to you all about getting on the same platform. Our goal today is to really start this whole journey together with understanding how we think of atherosclerosis, which is really the cause of heart attacks, ischemic strokes, microvessel dementia, peripheral arterial disease. How are we in this room coming at it from various specialties, whether it be family practice, whether it be dental hygiene, whether it be dentistry, whether it be cardiology, whether it be neurology, whether it be rheumatology. How do we bridge those relationships so that we create a whole person? And it takes all of us to do that. It's not, our bodies are not isolated into a mouth, a brain, a heart, a toe, a nose. We don't work that way. So let's get together and realize that heart attacks and strokes remain the leading cause of death and disability in this country. And I'm sad to say that strokes are occurring more and more frequently in younger women. Heart attacks, the recidivism rate is not getting better. So we've got to work together to change this whole paradigm, and it's going to take all of us to do it. Brad and I have coined a term. It's called Artery Ology, and it's becoming such a common word that everyone adapts to it quickly. What is arteriology? It's the study of the artery wall, not the lumen or the opening, but the study of the artery wall. And so that's what I want to talk about today. How do we find plaque that's hiding in the artery wall? And how do we all work from the medical and dental side to do a better job to find it and recognize it and deal with it? So that's what I want to talk about today. I'm going to talk briefly about vascular disease, just getting us on the page, same page on realizing this is a huge global issue. What are some red flags? And in your packet, you've got many of them listed. I'm only going to bring up a few just to prove a point. When you're sitting in your offices and you're identifying your environment, perhaps your environment is your waiting room. Perhaps your environment is bigger than that and you want to build your practice. Perhaps your environment is moving into a new community and you want to establish yourself as an oral systemic expert. Who should you look at perhaps a little bit differently in that city to market yourself and say, you know what, I'm a hygienist, I'm a dentist, and I have a bigger focus in mind here than just the mouth, which is very important. But I'm here to do oral systemic wellness. And who do you target? Who do you market yourself to? So that's where red flags come into play a little bit, and I'm only going to mention a few. That talk in itself is about an hour and a half long, so we're going to talk about a few of those. How do you talk to your patients about event reality? You cannot do cardiovascular prevention unless you have established a partnership with your patient. And as simplistic as it sounds, many patients who've just had a heart attack or an ischemic stroke don't really understand what just happened to them. They don't. So how do we articulate that very succinctly to our patients to say, this is what happened to you, or this could happen to you, and we're going to prevent that from happening again or ever happening altogether. That's event reality. What is atherosclerosis? How do you find it? And what do you do next? All right, so there's a sense of urgency to get this message out to both medical, and by medical, I mean medical, dental, and the general public. Vascular disease remains the leading cause of death and disability in this country. We can no longer rely on a risk factor paradigm alone, and I'm going to talk a little bit about that, because those of us in medicine are told to look at risk factors to assess our risk or our patient's risk. Why is that innately flawed? And let's talk about that a little bit, because you face the same thing in dentistry. Here's the reality, everyone. We spent $180 billion last year treating 12 inches of a 6,000-mile vessel system. And the majority of those resources were allocated towards loss of job productivity. This disease, called heart disease or vascular disease, is plucking people out of the workforce, placing them in a disability type environment, and it's costing us billions. We are going to go bankrupt treating vascular disease if we continue to focus on rescue medicine. We need to focus on prevention and not throw more resources at this, but simply change those allocation of those resources to really make a significant difference. Here's what the stats are. 1 million Americans suffer acute coronary events every single year, and 400,000 of those die from these events. It is estimated that over the next 2 decades, if we don't do something different, the amount we spend on this disease state will triple, going from $273 billion right now to $800 billion. unless we do something different. More effective solutions for prevention are needed, and that's why Brad and I have been so honored to work with Dr. Tom Neighbors, because we feel one of those solutions is to get us all on the same platform. And for us in medicine to say to dentistry, we need your help. We're clearly not doing a very good job here. We need your help. So that's where we're at today. Whose job is it? Whose responsibility is it to claim death and disability related to vascular wellness? Is it mine? Because I hang a shingle on my door that says the Heart Attack and Stroke Prevention Center? Is it a GP who measures your blood pressure and your cholesterol and says you're fine or not fine? Is it the cardiologist who puts in a stent or does a bypass, a cardiovascular surgeon, and says you're fine right now? I've just opened 2 inches of a 6,000-mile vessel system, you're fine. Whose job is it? I would say it's really all of ours. It's medicine, dentistry, rheumatology, dermatology. It's everybody who focuses on the body, because this is a systemic disease state. If we refrain from recognizing the urgency of the disease inflammatory relationship, and that's what we're going to talk about today, end-stage disease, or what I like to call rescue medicine, is going to continue to propel our efforts, and we're going to get nowhere. We're not going to get anywhere. So let's talk ever so briefly about red flags. And in your packet, you have a whole list of them. There's a lot of them. They're everywhere. You just need to know what to look for. And red flags are items or risk factors that may not have a direct cause and effect. And by cause and effect, I mean this. If you fix someone's lupus, will you eradicate their risk of having a heart attack? No. But if they have lupus, clearly there's an associated risk that they may have vascular inflammation. So what do we look at in our waiting rooms or on our H&P forms that we should maybe have the conversation with that patient as they're sitting in your dental chair? You've got some inflammation here, and you also have this condition called RA, rheumatoid arthritis, and I'm very concerned that with those two conditions combined together, we're going to have a problem down the road, and it could create a heart attack or stroke risk for you. So let's work together on that. So there's lots of them, and I'm only going to bring up a few just to prove a point here. So who should you look at in your waiting room a little differently? How about the idea of those of us in medicine at least handing out toothbrushes for people who come in for their annual physical, or handing out dental floss? That's our job in medicine. Do you think medical offices do that? No. Should they have the conversation during their physical and say, how often do you floss your teeth? How often do you brush your teeth? How often do you see your hygienist? How often do you see your dentist? What's your family history? Who in your family has dentures or implants, and why is that? That's our job in medicine, and we're missing the boat here. We're totally missing the boat, because for people who just don't brush their teeth very much, they're at an accelerated rate for heart attacks and strokes, and that's a big deal. Can you click, hey Brad, can you click on, for some reason it keeps pulling up this bottom bar, and when it does that, no, don't click on that, just move right up here, move up here, over here, over, and click. Thank you. Okay. Good job, good job. Okay, so did you know that a patient who has rheumatoid arthritis is just as likely to die, actually more likely to die from a heart attack than a diabetic? Slightly. Why is that a big deal? Because we don't know it. We in medicine and in dentistry don't talk about this a lot, and we consider type 2 diabetes a coronary risk equivalent in medicine. We say if you have diabetes, we're going to treat you exactly the same as if you had a heart attack. You need an aspirin, you need a statin, you need an ACE, you need all those things, right? But do we talk to our rheumatoid arthritic patients about that? How many patients, I'm just curious because RA is such a global issue, do you see, how many of you do you see a RA patient at least a couple times a week? I would say, yeah, it's a very common problem. And knowing that just because they have RA, you should be having this dialogue with them in your dental chair is important. Psoriasis. Psoriasis is a systemic inflammatory condition. We need to recognize it as such and realize that if our patient has it, the longer they have it, the extent, the severity that they have it, their risk goes up exponentially. It's almost like a linear progression as far as risk exponential. What about this? How about asking your women, do you have migraines? Oh, you have a migraine history? You have migraines with aura? you know, you're at risk for strokes later in your life. And data exists for men as well. We don't have the aura data for men, but we've got the aura data for women. That should be on your H&P forms. It's not just, perhaps it might be a bite issue, but maybe it's the pathology of the migraine, you know, who knows. What about this? Anxiety. Anxiety now trumps depression as far as a coronary risk factor. Untreated and unexpressed and undealt with anxiety is a big deal. So on your forms in your books, I did a couple things on that. I asked you to ask your patients, do you ever feel anxious and do you ever feel stressed? And we define stress as this: to be in an environment for which you perceive a lack of control. If your patient is in an environment, whether it be at work or you at work perceive a lack of control, or they're at home and we might perceive a lack of control, that creates an environment internally that's not good for the arteries. So ask your patient those questions, and then ask one more thing. Say, what do you do when you feel stressed? Are your outlets smoking, drinking, or are they exercise? Are they relaxing to soft music or good music or whatever? Because their stress adaptation techniques are also going to propel or hopefully mitigate some of that cardiovascular inflammatory process. So that's important, and that's our job, working together to make sure this is a reality. Work stress, everybody, does increase your risk. So one thing that Brad and I have said over the years is please get a mirror out, please. Just because you have a degree behind your name does not mean you're immune to this condition called atherosclerosis. Yes, heart attacks affect working people, so do strokes, and they also ruin your ability to continue to do what you love every day. So remember that work stress is important. If you learn nothing else today, it's that you can find out if you have risk and you can do something about it. Can dentists get cavities? Can hygienists have periodontal disease? Yeah. Can also have heart attacks and strokes. So work stress does matter. So get those programs within your work environment that are going to improve your team's health. Polycystic ovarian syndrome, that's an easy question to ask patients. That should be on your H&P forms. Referral sources, and I'm just going to cover these ever so slightly because we are here talking about how do you get patients into your practices. So I would encourage you to come to one of our 2-day courses actually and get this whole spiel, but I would also encourage you to just think globally. Any condition that has an inflammatory component is a potential referral source into your medical or dental practice, period. So you should be knocking on the door of your rheumatologist, you should be knocking on the door of your neurologist, your dermatologist, and getting those patients in to see you because all of these conditions have a connection. So who's at risk for a vascular event? Which one of us is going to have a vascular event in our lifetime? Many of us are. It's the most common cause of death and disability. So which one of us in this room, or how many of us, and who are we, that are going to suffer that sometime in our life? In medicine, this is how we're expected to assess that risk, by looking at our risk factors: our age, our gender, our smoking status, our total cholesterol, our blood pressure, our good cholesterol. And we throw that into a calculation and we say, oh my goodness, your risk is X%. So if your risk is low, we say you're fine, don't worry about it. You don't need any medicine, you're fine. You don't need to improve your lifestyle, or maybe improve your lifestyle a little bit, but you're okay. Or we deem your risk to be quite high. We're going to throw the book at you because your risk factor profile demands it. So is that effective or is it not? This was established in 1948, really looking at Framingham, Massachusetts and taking that town, and a lot of good has come out of that, and it still continues to come out of that whole Framingham database. But the reality is it's innately flawed. It's innately flawed because risk factors do not often or always tell the presence of atherosclerosis in the artery wall. That's like simply saying, by the way, in dentistry, I'm going to take your toothbrushing habits, your flossing habits, what you eat every day, and I'm not even going to look in your mouth. I'm just going to tell you if you have cavities or not. That's what we're expected to do in medicine. It's horrible. We need to look for disease. All right, so that's been challenged many, many times. In 2002, Dr. Acosta did a very simple study or analysis. He took basically 222 adults who had had a heart attack. There's no question that these people were at risk. And he calculated that Framingham risk profile I just showed you. And he said, hey, using the National Cholesterol Education Program guidelines, how many people did I miss? that had already had a heart attack. They missed 82% of the women and 66% of the men. Clearly, it's not good enough if this is all we rely ourselves on. Now, I tell you, we're getting better, right? We're improving slowly. Medicine is a long sort of engine or slow engine to make changes. The Reynolds risk score, which I think is better, the data would say it is better, incorporates everything with Framingham, but it includes some risk factor issues that are a little bit different, like things like HSCRP and family history. Adding those in does improve our assessment and actually has been shown to place 15% of people when compared to Framingham actually in lower risk categories and about 30% into higher risk categories, which I think is important. But here's the reality. These people are considered to be high risk. They have a 20% chance in the next 10 years of having a heart attack or an ischemic event. Reynolds does pick a lot more of them up, but only is getting about 60% of those people. And these are people who actually had heart attacks or strokes. So even with the improved assessment techniques, we're still missing 40% of people. It's not good enough yet. So are we okay? I hope we are, right? We're all here today. We have no plans to have a heart attack or stroke today, tomorrow, or the next day, because you all have busy lives to lead. Are we okay? Why is the current risk factor paradigm innately flawed? Why is that whole idea of just solely standing on risk flawed? Any thoughts? Why is it flawed? Yeah, it's not definitive, and you're not actually looking for the disease, are you? If you take risk factors for dental caries and don't look in the mouth and evaluate the tooth structure to know if there's a carie there, you're not going to see it, right? Risk factors do not tell you if your patient has hidden disease or not. And really, what causes an ischemic event? What are the risks? Is it risk factors or is it atherosclerosis? And are they one and the same? Let's talk about that. That's where, if I had to give you an elevator speech of what Brad and I have been up to in the last 10 years, or 11 years, I should say, I would say this. Look, the current standard is based on risk factors. We take all of our risk and we determine whether you should be on treatment or not on treatment. What we have done is said, okay, we're going to recognize that and we're still going to follow the standard of care. There's a lot of value there. The positive predictive value is great, by the way. If you fail your risk factor scoring profile, you probably have disease somewhere. But the negative predictive value is really poor, meaning if you pass it with flying colors, you could still have disease. So we have augmented the risk factor profile with a disease treatment paradigm, and that's what I want to talk to you about. How do you find disease and where does it hide? Because you and I can't feel it unless it blocks blood flow somewhere and we get clinical symptoms for it. So our method is really a disease treatment paradigm versus a risk factor paradigm. And our keystone here is really inflammation. That's what holds everything together. And that's why it's such a global approach. And today we have the honor of talking with the dental community, which is great in bridging those gaps. And we have a lot of work to do because we need to do the same with rheumatology, OBGYN, and everybody. And we're honored to start with the dental community. So here's what I want you to tell your patients very quickly, and I don't mean to oversimplify this, but I want you to have a very quick synopsis of being able to tell your patient what causes a heart attack or an ischemic stroke. What causes a heart attack or ischemic stroke is disease that lies hidden in the artery wall. When that disease misbehaves, when you get plaque that's hiding in the artery wall, in the intima media interface, and for whatever reason, usually we can determine the cause, you get a plaque rupture through that very protective lining called the endothelium. The body's autoimmune response to that, whether we want it to or not, is to do what? To heal it. If we cut ourselves, we're going to form a scab. We're going to heal, right? So if you get a rupture through that endothelium, and the body says, I better heal that, and we get a clot. Well, that thrombus, or clot, if it blocks blood flow in the heart, we call it a heart attack. If it blocks blood flow in the brain, we call it a stroke. What about the concept of this? What about if it's a microvessel thrombus that wants to drift around and lodge itself in the small little tiny capillaries of the brain? And over years and years of that, we then say, oh my gosh, have you noticed Grandma's memory is getting a little bit poor? She has dementia. It's really atherosclerosis. So that's what really causes an event, is a thrombus. So how do we find out if plaque is here, find out the reason it's there, treat it, see the inflammation associated with that disease, mitigate, and not ever allow a thrombus to occur? Now that's prevention, right? So what really causes a heart attack or stroke? Here's something I want to throw at you because it's a really interesting concept and I think misperceived. Many of your patients will come to you and say, well, yeah, I know I have maybe some risk factors, but I do a stress test all the time. I go in, I mean, I've got a great doc, and boy, I'm doing a stress test every couple years because I know I have a family history. Do you know that that stress test is only going to be abnormal if you have about a 70% blocked vessel? Do you know that 86% of heart attacks occur in vessels that are less than 70% occluded? I mean, think about that for a moment. So you go past your stress test, congratulations. At that moment, we can say you have no blockage, but it doesn't mean you don't have hidden plaque in the wall. It means you don't have a blockage at that moment. That's a huge problem because patients are given a false sense of security oftentimes. Here's the reality. Plaque is smart. Our bodies are smart. We are built innately to survive, aren't we? So with every ounce of who we are, we will silently, just biologically deposit that plaque, fatty streak, the whole 9 yards into the artery wall, virtually out of sight, out of mind. So you don't see it if you look through the lumen. So what are some of those tests like? Things like the Lifeline screen, right? That goes around and they do a little modified duplex and they say, oh, you look good. Oh, you look good, you passed your stress test. Oh, your angiogram, it looks good, wide open. It doesn't tell you if plaque lives in the artery wall. There's a huge misconception there, and I have yet, over the last 10 years, had anyone come to my door and say, Amy, can you check me out? I feel like I have a little bit of fatty streak building up in the wall of my artery. No, your patients aren't gonna tell you that. You need to find it, that's our job. We need to be investigators and we need to find this stuff, because if we don't, and your patient has, let's just say, periodontal disease and an inflammatory backdrop that allows that plaque to rupture through that endothelium, and the body says, hey, we've got an injury. I'm going to heal that. And we also know, and we're going to talk about today, how those bacteria that live in the gum line also create a prothrombotic state. So not only are you more likely to have a plaque rupture, not only are you more likely to build plaque, but you're more likely to form a giant old thrombus on there because it increased the platelet aggregation, and that blood clot is going to do something bad somewhere in the body. So it's dentistry's job to help us make sure that doesn't happen, because if we don't, we're missing the boat entirely. He's not paying attention. So we have given a name to plaque as the cat in the gutter because it hides there. And we don't know it's there until it wants to leap out and cause a huge problem. We all live our lives, we wake up every morning just like Tim Russert did, right? Wake up every morning and we think, you know, we're going to be fine today. And if that plaque actually ruptures or misbehaves, then we're going to have a huge problem.
Glad you came over. I wouldn't want to tackle that one. Looks way too complicated.
I don't know. That's weird. Anyway, so we need to find out if a cat is in the gutter or not. So I want to throw a concept at you a little bit. How are we doing on time, guys? Can someone tell me? Okay, good. Okay, so direct comparison of risk versus disease. This is a really probably oversimplistic study that Brad and I did within our clinical practice in Spokane years ago, and I want to prove a point to you. We decided to compare risk factors with disease. If we simply focus on a tunnel of looking at risk factors versus if we do something to look for disease in the artery wall, are we going to have a better outcome to know who's at risk and who's not at risk? So I'm going to tell you this really, really quickly. We had just pooled together 576 of our patients. We said, let's look at this group that has had some sort of structure testing or some sort of imaging done. We determined out of this 576 patient database that some of them were deemed to be at risk for a heart attack or stroke. Why? Because they had something to tell us that. They either had a heart attack before, they had a stroke before, they had a stent, they had diabetes, they had known disease somewhere, whether it be a coronary scan or a carotid scan. They had known disease. We figured, well, that's fair. Those people, because they have plaque and it's been proven based on their medical history that they are at risk for some sort of event. And now let's wipe the slate clean And let's look at those people we deem to be at risk, which we included 408 of them to have one or more of these conditions. Are you with me? And let's take those 408 and let's just wipe the slate clean like we don't know them. And let's just do a Framingham score, a risk factor analysis, or let's do a disease treatment paradigm and see how many we pick up. Here's the results. If we simply relied on risk factors alone, we only identified 14% of those people who were at risk for heart attack or stroke. If we did some sort of imaging, and I'll talk to you about what we did, we identified 100% of those at-risk patients. So that's the concept we're talking about today, and I want to talk about your role in this disease paradigm because it's essential. It's essential. We know that it's complex. It's not as easy as just a heart attack or stroke. That's what we talk about all the time because they cost a lot of money and they stop our lives, right? But really what happens most of the time if you're harboring silent plaque in the artery wall, well, three things can happen basically. One is you get a plaque rupture and a massive thrombus that causes what we call ACS, acute coronary syndrome, a heart attack with no warning. Or the majority actually cause microvessel plaque ruptures and microthrombi that drift around and cause things, as I said, like microvessel dementia, erectile dysfunction, peripheral arterial disease, macular degeneration, things that affect our ability to live independently and live the way we want. That's the majority of this disease state. The third thing that can happen is you can get plaque rupture and scar tissue, so over time those lumens do narrow and people have chest pain with exercise and angina and you know, again, just lumen diameter change over time. So we're talking about a systemic condition, not just heart attacks and strokes today. So how do we define an event? Of course we can talk about heart attacks or ischemic strokes, but remember we're talking about the whole body here. So your role is much bigger even than just heart attack and stroke prevention. Dentistry can allow your patients to live well until they're 100 in their own home if they choose to. That's our hope. That's our own hope, right? And our patients' hope as well. So basically, atherosclerosis is sine qua non for an event period. If you find it somewhere, it has a chance to misbehave. So how do we find it, right? Let's talk about that a little bit. And the key player here when you talk about heart attack and stroke and atherosclerosis is inflammation. That's our bridge, right? So we're going to talk about how periodontal disease and dentistry is key in that inflammatory pathway. So it's one thing to have plaque and be inflamed, or another thing to have plaque and have a non-inflamed environment, because you can live a long and healthy life with plaque from head to toe, as long as it doesn't misbehave. This is what we focus on so much, just these vessels around the heart, but what I want you to think globally is that we're dealing with this system, artery ology. It's the whole body. The arteries are the highways that feed nutrients to everywhere. So yes, what goes on here is going to affect the systemic circulatory system as far as inflammatory pathways. It's just inevitable. So it's a much bigger picture than just that or that. It's the whole body. What is luminology? Luminology is classic cardiology, and it's with huge respect that I say cardiologists in this country have never been better at preventing death if someone's in the ER with a heart attack. The time to cath lab has never been better. The survival rate for heart attacks has never been better. But why are people still having them then? Why are people still having events all the time? And why are they having repeat events? Because if we only focus on luminology, we're going to miss the boat to where disease actually lives. Because classic cardiology is focused on this. So stress tests, duplexes, angiograms. Those are to look at the lumen opening only. Arteriology is the focus on the artery wall where plaque actually lives. That's what you want to know. Do you have plaque in the artery wall? Because if you do, you have atherosclerosis, and it has the potential to misbehave. So wouldn't it be nice if you had a little, little wand you could wave over to all of your patients and say, oh, you've got some plaque in the artery wall. I want you here in to see me every 3 months. Not every 6 months, not every year, every 3 months, because you're walking around with this. And I don't want it to rupture. Wouldn't that be nice to have a little wand that you could know that? Our statement is you can have that wand. There are tools that can tell you if your patient is here or are they not. So that's where arteriology comes into play. It's a different way to look at the artery wall. Healthcare providers who specialize on the health of the artery wall and appreciate the connection between atherosclerosis and inflammation, that's an arteriologist. You are all arteriologists. That's official, hands down. Without your help, we can't fix this problem. So plaque is a cat in the gutter, as I said. You know, I'm having problems with this guy, and it's fully charged. Oh, there we go. Define each patient. Primary prevention is really what we call the superior setting, or when Tom talked about superior physicians and doctors and dentists and hygienists. Primary prevention is really no plaque in the arterial wall system anywhere. The goal of treatment for that patient is to never, ever, ever let plaque develop in that artery wall. Secondary prevention are individuals that have plaque in the artery wall, and the goal is to never let it rupture. Tertiary prevention, these are easy to pick out because they've already had a heart attack, a stent, a stroke to prove to you that they have plaque. The goal of treatment is what? What do you think the goal of treatment is for tertiary prevention? To never let it happen again, right? Recidivism is horrible, horrible. It's like a revolving door in the cath lab. Brad's daughter Brittany works at Vanderbilt, she's an advanced cardiac nurse. She says she knows the patient's name. It's like they're in all the time. Oh, you're in again. Oh, you're in again. Hello, Mr. Jones, you're back in again.
Oh, she knows her pets' names too.
And her pets' names, and their pets' names,
Dogs
yeah.
and the cats.
I mean, recidivism is a huge problem in this country. So we define patients in our practices, and we encourage you to do this as well. Find out if your patient is primary, secondary, or tertiary, and at the very least, find out if you are primary, secondary, or tertiary. Because contrary to popular belief, this is not an age phenomenon. Once we're 50, we all have plaque. No way. No way. And yes, you can have plaque at a young age as well. So it's not an age phenomenon. It's a genetic phenomenon, really, and an inflammatory phenomenon. So step one, find out who has disease. How do we find it? Knowing that the disease is silent until we get a plaque rupture and a big old clot to tell us it's been there. How do we find it before that happens? Stress tests, I already mentioned this, they're really designed for the lumen. It's a luminology test. So yes, your patients can have a perfect stress test. Yes, you can go out and run a marathon. A stress test is 12 minutes. You can go run an hour. You just did your own stress test, congratulations. And you can pass it, right? You could still have disease. It only tells you this part. Your patients that go in for a lifeline screen spend $150, right? They're looking at this part. Doesn't mean they're free of atherosclerosis. Why do we do stress testing? To find out if your patient is okay lumen-wise. So there's lots of reasons, but we're talking about arteriology today. Coronary calcium testing, I just am simply bringing this up because it's a very commonly used tool in the medical world. It's basically an x-ray of the heart. And all we're doing there is trying to find out if calcium deposition is present in any of those arteries around the heart. And if it is, it means that you've just diagnosed coronary artery disease. So here's a concept for you. That fancy CT scan of the heart is simply, like I said, an x-ray of the 12 inches of vessels around the heart muscle. You with me? So what about x-rays of the lungs? Could you find calcification in any of those arteries? What about a panoramic x-ray? Could you see calcification in the carotids on a panoramic film? Can we, with just the technology of x-ray, find atherosclerosis? And the answer is yes. It's just called fancy. It's a coronary artery calcification scan. That's all it is. Looking for calcium in the artery wall of the heart. Now, one thing I will tell you with a calcium scan or an x-ray of any type or a CT scan, it can only tell you the hard stuff. For any of us who are runners or athletes, right, you get an x-ray of your knee because you think, oh man, something's clicking in there. Is an x-ray going to tell you if you have a soft tissue injury or a meniscal tear? No. It tells you if calcification or some sort of hard tissue thing is going on. Same thing with this or any x-ray. It tells you perhaps the tip of the iceberg, because what happens early on with atherosclerosis is it builds, and as it's building in the artery wall, it's soft, it's non-calcified. Once it's either treated or it's been there long enough, the body's natural process will heal it, and we can sometimes pick it up on an x-ray. So my only thought here is, once you find calcium in any arterial bed, it's been there a long time and long enough to show calcium deposition. What you don't know is what's behind the surface, how much soft stuff is under there. Does that make sense? And sometimes it's the soft stuff that's even more risky than the calcified stuff, because that's more active and more likely to rupture. So just remember that when you're looking at even your panoramic films and things. Calcium in ruptured plaques quantitatively have less calcium. In other words, treatment, we hope, calcifies plaque, because we want to stabilize what's there and prevent new stuff from growing. So treatment will heal or calcify plaque, which is sometimes a hard concept to gather. But we want to heal plaque that's there and not let it rupture, and that means we stop the inflammatory process of it. So my only one caveat here, if you don't see calcium in an artery, it may or may not mean that atherosclerosis exists, because if your technology only looks at calcium, you may have soft plaque that hasn't been there long enough to calcify. So keep that in mind as well. So your oxymoron for the day is, you know what, I just did a calcium scan of your heart, and you know, I looked for calcium, and you just barely have any there. You have a score of 4. That's hardly anything. Congratulations. That score of 4 means you've identified a tip of potentially a huge iceberg underneath the surface. So if you find calcium anywhere in an arterial wall system, it's a big deal. And it's your job to tell the patient about what that means. And it's your job to work together to make sure that never ruptures or causes problems. Do we need to limit our assessment to just the heart, or can we look elsewhere? If I told you we have 6,000 miles of vessels, can we look somewhere else than just the 12 inches here? Sometimes those are hard to get to. What about the concept of looking at any vascular bed? We know that if you find plaque here, you find plaque here, you find plaque here, you're perhaps even at more risk for an event than if all you do is find plaque here. So wherever you find it, it's a big deal. You need to deal with it and recognize it. Looking beyond the heart real quickly, pay attention to all these things. Even, if you get the chance on your patient's histories, you're not looking for calcification in the tissue, but you're looking for calcification in any arterial bed. Case in point, even carotid calcification on dental x-rays signals increased cardiovascular risk. What about if you had an internal protocol within your office that you were all trained to look for things like this? These are courtesy of Dr. Tom Neighbors, thank you, Tom. These little areas of calcification within the carotid arteries. You could save this person's life, because you know what? You can say to them, oh, Mrs. Smith or Mr. Jones, dentally, well, they have no teeth, right? Dentally, you have no teeth, I hate to tell you, but you do have atherosclerosis. We just found plaque in your carotid arteries. We need to make sure and know why that's there and go for the why here. But anyway, keep in mind, any place in the body that you find plaque, it's a big deal. So the good news is your teeth look great. The bad news is that you have calcium in your carotid artery. So have some internal protocols and get yourselves trained on looking at those panoramic x-ray films. You're missing the opportunity there to really diagnose atherosclerosis. B-mode ultrasound is a great technology and has really been a workhorse tool for us clinically in our practices and for those around the country who do prevention. Carotid artery ultrasound, B-mode ultrasound, looking at the wall of the artery, called Imt Thickness Testing, has been around for a long time. It's been backed by the American Heart Association for the last 12 years to say, hey, look everyone, here's a safe, reliable, reproducible test to tell you if plaque lives in the artery wall or not. Use it. And where are we today? 12 years later, it's still slowly gaining traction. Slowly gaining traction. It's a technology out there to save lives. It's very different than a carotid duplex, right? Because a duplex is going to look here. The CIMT, the mean, is going to look at the average thickness here, because we know what's normal, by the way, down to about age 5 all the way up to 80, based on gender. And we're getting more ethnic diversity data, which is great. So you can know, well, gosh, I may be 42 years old, but maybe I have the arteries of a 60-year-old. Oh man, like, get me on board here. I want to know if I'm okay. I want to know why that is. Or does plaque exist in the artery wall? Plaque is really given to an area of thickness that meets or exceeds a certain cut point. 1.3 millimeters is the gold standard right now. So you can have a perfectly normal duplex and have plaque hiding in the artery wall and not see it. That's a really important thing to recognize. We know what's going on here has been correlated via several different large study groups to say if we find it here, it's also probably going on in the heart. So it's a nice surrogate marker for even coronary disease as well. So if you find it in the carotids, you've identified a systemic process of atherosclerosis. Whether you find it with a formal test like a CIMT or you find it on your panoramic x-ray films, you're looking for plaque or atherosclerosis. Is it a normal stage of aging? Do we all have it? The answer is no. They've looked and they see that, my goodness, some people have it. About 55% of people, once we reach around age 60, have it, but not everybody. So don't assume because you're young or you're over 60 that you'd have plaque. Absolutely not. You need to know and you need to find out. Okay, here's a challenge that I have for you today. Cardio Risk is here in the back, and it's a CME program, so I'm not going to talk too much, but they are very gracious to be here on their own time. And they are offering you the opportunity to get a coronary, a carotid IMT test. And I think the cost is around $99, which is a huge steal, and it can save your life. And I'm going to give you a challenge. If you go out there and you get a scan today, and you find plaque in the artery wall, can you just say, la, 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 I don't want to know, I don't want to know? Can you ignore it? Because I guarantee you won't feel it. You won't feel it. Can you ignore it? Well, that's been tested. They looked at 10,000 of us, followed us for a decade. Let's place us in this trial. Let's pretend we're 10,000 members strong. Won't that be great when that happens, right? 10,000 members strong. And we all do a carotid IMT test. And we find stuff in there, right? We find plaque or we don't find plaque. Age range, look at the age range, 35 to 65. That's a very nice assessment of our group. We did B-mode ultrasounds of the carotids. They also added in the femorals, which is nice. But here was what we all had to sign. We had to say, no matter what you find out in that hallway today, whatever Cardio Risk tells you, you can't do anything about it. You can't treat it because you're asymptomatic, you can't feel it. We're just not going to treat it. And we're going to watch us for 10 years. We're going to see what happens. Class 1 means many of us don't have any thickness, we don't have any plaque, we're actually looking really good, which is great. Class 2 means maybe our age matches elevated. Maybe we're of a certain age, but our age matches maybe 10 or 12 years older than our chronological age. Class 3 are those scary folks that have plaque and don't know it. It's hiding in the wall. Class 4, some of us have plaque, and so much plaque, in fact, that the artery wall the lumen is narrowed. But still we can't get treatment. Please notice the publication date on this, 2001. This is a long time ago. We can't recreate this study because it's unethical. My question to you is, for those of us that may have plaque in the artery wall and we don't know it, if we don't do something about it over the next 10 years, 4 out of 10 of us in this room are going to have a heart attack or stroke, regardless of what our risk factor profile looks like. Do you get that? So if you find calcium on a panoramic film, or you go out and you do your IMT, and you find plaque, do something about it. And we're going to talk the whole day on what to do about it and how to assess and figure out what to do. Here's something I will tell you. You may be surprised. You may be surprised. And you don't want to be surprised, because our other option, the fear of saying, okay, I'm gonna get this scan. The fear of doing that sometimes paralyzes people from doing it because they just figure, I don't want to know. But I'll tell you something, if you don't do something to know that it's there, you could wind up into problems, because the other way to find out is if you have a heart attack or stroke to prove it, period. Knowledge is power. Find out if you have plaque. Nothing's better than to find it on paper. I'm going to talk to you about Patty. I've shown her case before, and I'm going to stop on just whether Patty has disease or not, or risk factors. So let me introduce you to her. 58-year-old female. She stands 5'6" tall. She weighs 133 pounds. Her waist is slim, 27 inches. Blood pressure, and she's on no medicine, 120/66. Pulse is 52, respiratory rate is 16. Are we okay with Patty so far? So you can see Patty sitting in your waiting room, waiting for her checkup, right? Diagnosis. Patty has mitral valve prolapse and has for a long, long time. Why am I telling you that? Not that that's an atherosclerotic condition necessarily, although there's some question about that. The reason I'm telling you that is because Patty's not naive to medicine. She's gone in routinely for echocardiograms to look at those valves and make sure that her heart valves are working okay. So it's not like that mystery patient that hasn't been into any medical platform for the past decade and a half. She goes in regularly and she gets a checkup, and every time she gets a checkup they say, Patty, you look awesome. Your blood pressure looks great. Thank you for not smoking. Thank you for being so fit. God, I wish everybody was like you. That's what she gets told every time. But this is interesting, isn't it? What kind of condition is gout? It's an inflammatory condition. How weird, right, that this skinny little lady gets gout every time she goes on vacation and slips up, has some aged cheeses, maybe a steak with her husband every now and then. She gets gout. Who gets gout? Also, Patty has psoriasis, and it's bad. She's had it her whole life. Her brother has it too. What kind of condition is that? Inflammatory. So she's got a couple red flags that would say, Patty, I know everything looks good. I know you look good physically. I know your cholesterol looks good, blood pressure looks good, your weight, your waist. But God, you've got these red flags. I'm not quite sure if you're okay or not. She has a hypothyroid condition that's regulated with medicine, so she's euthyroid. Vitamin D, she takes vitamin D regularly because she lives in the Pacific Northwest. Everyone's low. Review system's asymptomatic, and this girl exercises all the time. She's got the outfit to go with Pilates. She's got the outfit to go with spinning. She's got the outfit to play tennis in. I mean, she's got it going on. She's fit. She wants to live well. Family history, her dad lived to be 84 and was told he died of old age, but her dad's dad did die of a heart attack in his 50s, which is kind of interesting. Mom lived to be 73, but she died of heart failure. Her brother had a heart attack at 63. 63, that's young. And her other brother has psoriasis, so she had some concerns. What are her red flags? Why would we pick Patty out of the waiting room and say, are you okay? Gout, you already called it, psoriasis, and some family history. So just for fun, let's look at Patty's cholesterol. And I know we're not here on a cholesterol lecture, but I will tell you, even coming from a picky Pete personality that I have, that looks good. Her cholesterol looks good. Total is 217. You may say, well, that's a little high, but the majority of it is the good cholesterol. It looks good. Her LDL looks good. All the bad stuff looks good. Ratio for women. For those of us in the room who are women, you know that women's health trial that was so messy that tell us if we should be on hormones or not on hormones, and it all came out. 27,000 of us followed for 11 years. At the end of that expensive, long, drawn-out trial, we said, I don't know. I don't know what to do with hormones. So that trial, although it offered a lot of controversy, in February of 2010, they went back into that database because it was one of the best trials they have for us as women. And they said, which lipid out of the 27,000 women followed for 11 years was most predictive of who in that group was going to go on and have an event, a heart attack or stroke? It wasn't this, or this. It was this, total cholesterol to HDL ratio. And if that was over, well, I shouldn't give you a hard amount. You really want to see it less than 3. So in reality, even her ratio looked good. She did not have a cholesterol problem. So calculating a Framingham score, which takes Patty's age, gender, the fact that she doesn't smoke, a systolic blood pressure of 120, an HDL of 97, a total cholesterol of 217, throw it in a calculation, and I say, Patty, oh my gosh, you have a 1% chance in the next 10 years of having a heart attack or stroke. Patty says, hey, I'll take those odds. I'm going to continue to live well. And we say, well, gosh, you know, there's this new thing out there. It's called the Reynolds risk score, and it reclassifies a lot of people. It adds in things like HSCRP. It's going to add in your family history. Is that going to help us? Still a 1% 10-year risk. So we would say, based on everything the standard of care in medicine would offer us for Patty, we would deem her to be what? Fine, right? Big question, does she require treatment? Does she? or does she not? Do we or do we not? Should she be into her dentist every 3 months or every 6 to 12 months like she is now? Right? How do you know that? We must first ask this, does she have disease? Because if we know if Patty's primary, secondary, or tertiary, we know she's not tertiary, but does she have plaque or not, may change our whole idea of health maintenance for her, right? Does she have disease? Well, a couple of tests we do routinely, an ABI, which is a lumen test, sure, but it looks at blood flow to the toes, she nailed it. Did an EKG, because it's nice to have on file, that was fine. Looking over her chart, like looking through her past medical history, there was an old chest x-ray that she did approximately 7 years ago prior to coming in to see me. And she had that done by her medical provider who wanted to rule out pneumonia because she had a cough. And she was told she was fine, had no infectious process, did not have pneumonia. And you know what they found on that chest x-ray, or it was noted? Microvessel calcifications were noted in the aortic arch. Patty's been walking around with 7 years with known calcium in the artery wall somewhere. Now, it's not been qualified or quantified, but I asked Patty, did anyone tell you about that? She said, what are you talking about? That time I had that cough? No, I nailed that x-ray. Told me I was fine. And I said, yeah, from a respiratory standpoint you were. But you have atherosclerosis, Patty. Now let's do something to quantify and qualify it a little bit. Let's get an IMT. Now this is a report from Cardio Risk who's out there. So this is what your report will look like. Well, here's Patty, who's 59 years old at the time we did her very first IMT. Based on this measurement right here, the average common carotid artery mean IMT, 0.88. It was greater than her age by over 20 years. When did that start? I have no idea. It could have started when she was 10. By the time she was 12, it was, you know, 8 years old or whatever. This process had been going on, and it was inflammatory, and she had a thickness of this artery wall. What about plaque? Did she have plaque sitting there? Anything over 1.3 millimeters is plaque. She had an area of 3.9 millimeters. Why didn't she feel that? Why didn't she say, you know what, I'm here because I think I've got some plaque here? Because it hides in the artery wall. It would only show itself if it was to rupture and get a thrombus. What else is here? It's soft, it's active, it's inflammatory. It's a huge issue. She's at high risk for stroke. So here's the other thing with her. Just real quickly on some data. If Patty at the bifurcation, and we see right at the bifurcation her bulb, it's 3.9 millimeters, data has been showing that if it's just over 2.45 millimeters, her lifetime risk of having a stroke is 75%. However, her Framingham score said she only had a 1% chance. Her Reynolds risk score said she had a 1% chance. Blood pressure was perfect. LDL was perfect. She is a walking time bomb. And it was simply standing on a disease treatment platform that made all the difference. And that actually was originally diagnosed with her chest x-ray. Yes?
So that can be measured with the company? I mean, are you saying as a dentist we can measure?
No. From the dental perspective, and Tom, you might want to chime in here, all I'm saying is don't miss any opportunity when you have a chance to look at our arterial system to recognize calcium, because on an x-ray system you can identify calcification. So if you look, I don't know what the word cone be, I don't know dentistry, but on a panoramic film, if you see calcification in that carotid, you've just diagnosed atherosclerosis. It's very different than an IMT test, which actually is utilized to not only find plaque, both soft and hard, and get a mean thickness, but to use to follow disease over time. All I want us in this room to realize is that we all have capabilities to look for atherosclerosis, whether it's looking at our chest x-rays a little different, our mammogram reports a little different, our panoramic films a little differently, or even incorporated technology like carotid IMT testing to know if your patient has plaque and to give you a foothold to know what you're dealing with. Did that answer your question or not?
Might add a little color. The clinical application to the hygienist to dentist, I think that's the question. Is that right?
Well, we have a technology
Yes. Yeah. Right. Yeah. Sure.
Wow.
I think the point that Amy is making here is that our job is in the dental office is a screener, not as a diagnostician for cardiovascular disease. So when we see calcification in a carotid, that's a red flag. And so that's what Amy is saying, that we need to find a provider that can provide this kind of testing so that we can definitively determine if there's disease there, and if that disease, well, already there is disease there because you've discovered it, but we need to know how large it is, how active it is, and who's going to treat it. So we're not to diagnose at this point, but we are to certainly refer at this point.
Well, and the other thing too, thank you for that, Tom. The other thing I want to keep in mind here is that if you find it here, you've just diagnosed a systemic process. You've diagnosed a systemic process of atherosclerosis. The body is built to protect the brain for as long as possible, so usually there's no always in biology. By the time you find it here, you can usually find it distally. So if you see something here that says this isn't right, you've just diagnosed systemic atherosclerosis and everything's changed. Because you know that patient has plaque, you know that plaque can rupture, you know that a rupture can create a blood clot that can stop their life cold, or create things long-term like dementia and things like that. So the world of dentistry needs to make sure that there's no inflammatory component coming from here that could allow that plaque rupture. That's what I'm really saying. Does that make sense? Okay. All right, so the link between vascular disease and coronary events is really inflammation, and that's what Brad's going to talk about next. That's really our goal here, is to make sure that if you find atherosclerosis, that you recognize that inflammation not only causes it, but can cause it to leap out, and that's what Brad's going to talk about next. How do you find it? How do you assess for it? And where does the dental component tread on the vascular territory as far as vascular inflammation? So I'm going to go ahead and stop there and let Brad take over from the inflammatory side. So thank you very much. Thank you.